for a lot of procedures, um, there's plenty of data that shows that the way we're diagnosing today is not credible. We know that half of back surgeries are unnecessary. We know that. It's well documented, well demonstrated. The orthos know this. Just every patient who walks in, no, you're one of the good ones, right? Like you're not the half that is unnecessary. Yours is definitely necessary, and we continue unchanged. Um, but if you have requirements like you're saying, we already have those requirements in place for other things. We just need to be consistent.
Well, and your example is a good one because when it is done well, people there isn't noise. Like we put a
Yeah.
surgical COE in, and a big part of that was avoiding surgeries. And so we followed those people to see were they going back through the broader network and having the surgery, and they weren't. So something was being done right in terms of having the conversation with the individual about why surgery was not going to help that
Right.
person. So it has to be done well. And I think of like our prior authorizations, we deny more than half. And you would think that would create a lot of noise when you compare like the big three are in the 85% approvals.
Right.
You'd think we would have noise, yet our net promoter scores are really high. And the reason for that
Hmm.
is it's being done well.
Isn't
It's
that
being done.
interesting?
A clinician is speaking to a clinician, so it doesn't give the doctor the opportunity to kind of badmouth the insurance company, right?
Right.
So
Right.
when it works well and there's data and science behind it, and you have educated people delivering the message,
Yeah.
it works. So we just have to avoid having people who aren't clinicians, who aren't trained, delivering these messages because that the member doesn't believe it. They think it's trying to save money, and they don't believe it's not for their health, the best outcome for them.